A very good afternoon to everyone. My name is Dr. Sky. I'm one of the Family Physician Associate Consultant with Bukit Batok Polyclinic under the National University Polyclinics. And today we are delighted to have one of our speakers here, who is Associate Professor David Allen. He's a distinguished infectious disease expert and is currently an Associate Professor in the Yong Loo Ling School of Medicine, National University of Singapore. And he's a Senior Consultant with the Division of Infectious Diseases with the National University Hospital and a Visiting Senior Consultant with the NCID. He also serves as the chairperson of the expert group for the ACG for urinary tract infections, appropriate diagnosis and antibiotic use for uncomplicated cystitis and pyelonephritis, which focuses on the accurate diagnosis and judicious use of antibiotics for uncomplicated cystitis and pyelonephritis. So without further ado, can I invite Professor David Allen, please?
Thank you, Dr. Ko, and thank you to the organizers of this symposium, this discussion. These are the members of the expert group. We have a wide variety of expertise available. So here is the guidance. It is written, for those of you who haven't seen it, it is written in a manner to really deal with practical issues and questions that arise, and that this is the best evidence-guided management that we can provide in Singapore at this time. So the purpose of talking about antibiotics and how to diagnose these circumstances is to be more practical in our antibiotic use and decrease antibiotic resistance development. We know the main causes of urinary tract infections are E. coli. We know we have a significant amount of ciprofloxacin and cotrimoxazole resistance locally in our E. coli, and specifically in our outpatient urine isolates. And we know that if we use antibiotics promiscuously or inappropriately, that we're not helping the community or our individual patient. So this is the approach. This is a summation of what we're going to be talking about over the next 25 minutes or so. And let me just walk through this without going into excruciating detail, but it is, at first glance, it's a little complicated, but once you work through it once or twice, it becomes relatively clear. Essentially, if you have urinary symptoms of new onset, such as frequency, urgency, or dysuria, and you don't have a flank pain, nausea, vomiting, and you have two of the urinary symptoms, frequency and urgency, or urgency and dysuria, etc., then that fits criteria. That's a highly positive predictive value that you have uncomplicated cystitis, and we'd go to empiric treatment, which we'll talk about later. The key bits of this guidance are figure 2, which is what I'm showing, and then table 4 and table 5. Those are where the rubber meet the road. Those tell us how to go about doing this and what are the antibiotic, our first option, second option, etc. The rest of the guidance is extremely useful, trying to provide a little bit of, or a significant amount of support for those guidance. But if you're really in a hurry and just need to look at 2 or 3 things, those are the things to look at. If you're uncertain whether if they only have one urinary sign and symptom or symptom and you're uncertain, then you do a dipstick. If either leukocyte esterase is present, if either leukocyte esterase or nitrite is present, then they again fall into the category of uncomplicated cystitis, and we treat empirically. If not, then we'd do additional non-antibiotic treatment to try to determine what is the etiology of their symptom complex. Again, if they do have flank pain or systemic signs, let's keep on this slide, thanks. Then we're worried about pyelonephritis. And we do appropriate diagnostics, either a dipstick or microscopy plus culture. We're doing a culture to help guide us. And we fall into the treatment category, and the guidance is provided by table 5. So just to reemphasize, the guidance recommends avoiding routine screening for and treatment of asymptomatic bacteria. If someone doesn't have urinary tract symptoms, we should not be looking for it because there's a high prevalence of bacteria, particularly in postmenopausal women, and it does not correlate with subsequent complications. Treating asymptomatic bacteria, which we have all done for lack of anything else to offer, may be associated with an increased chance of a true symptomatic bacteria that syndrome or state of asymptomatic bacteria is actually suppressing subsequent pathogenic invasive bacteria from occurring. That is not a universally accepted theory, but that is certainly one theory. But we do know that treatment of asymptomatic bacteria does not prevent subsequent acute cystitis, and it does lead to increasing bacterial resistance. So avoid screening for and treating asymptomatic bacteria is mentioned. As defined, asymptomatic bacteria is greater than or equal to 10 to the fifth bacteria in the urine without acute UTI signs or symptoms, dysuria frequency, urgency. And why are we not doing this? There's no difference in frequency of outcomes. There is some data, as mentioned, that it might be increased frequency of symptomatic urinary tract infections by doing so, and the risk of antibiotic resistance, and obviously cost and resources. So here's a poll. If someone comes in classic symptoms and they have two symptoms or signs, and they don't have evidence of a systemic illness, fever, nausea, etc., we don't need to do a dipstick. We don't need to do a culture. We don't need to do microscopy. We treat empirically. The data, it's a very high positive predictive value based on symptoms alone, classic symptoms that they have a acute cystitis, and we treat. Boom. So the answer would be C, the start empiric antibiotics without further investigation at that point in time. Okay. Now we're going to talk about, we've already spoken a bit about diagnosis and management. Let's go to the next slide. The second recommendation: diagnose uncomplicated cystitis based on history and presentation in patients with two or more typical symptoms or signs, as mentioned, and don't have vaginal discharge. Vaginal discharge is not a symptom or sign of urinary tract infections. The presence of a vaginal discharge makes us think of other differentials, which we'll raise in just a moment. So uncomplicated cystitis is based on history and presentation in patients with greater than two typical signs or symptoms. So absence of vaginal discharge plus dysuria and urine frequency and urgency, two of those latter three items would be sufficient to be able to say this person has an uncomplicated cystitis. There are certainly other signs and symptoms we see in people with acute bacterial cystitis. Don't get me wrong, but their sensitivity and specificity are not as high as with dysuria, urine frequency, and urgency in the absence of a vaginal discharge. So we certainly see this and take them into consideration, but they're not quite as compelling. You can see the vaginal discharge really decreases the likelihood that this is cystitis. And you can see the other considerations there, including painful bladder syndrome, which is effectively interstitial cystitis, sexually transmitted disease, etc. The next recommendation: if there's uncertainty, meaning you only have one sign or symptom, and you're trying to confirm, so you're unsure, then that's the time to do a urine dipstick. So that's what's recommended. If someone has recurrent cystitis, not bacteriuria, but recurrent cystitis, or it's unresolved after appropriate empiric treatment, then do a culture and sensitivity. So when there's uncertainty, again, do a dipstick. When there's unresolved or recurrent cystitis, do a culture. Nitrite and leukocyte esterase, either alone or both together, is correlates very highly with the presence of a urinary tract infection in the setting when someone has symptoms. In the setting when someone doesn't have symptoms, then the urine dipstick is not helpful. It is symptoms that distinguishes an asymptomatic bacteria from acute bacterial cystitis. And again, in those who are having either relapsing or persistent cystitis, then we need to find out certainly if it's a resistant bacteria or something else going on. And so doing a urine culture would be appropriate at that time. So again, acute uncomplicated cystitis, meaning not in pregnancy, not in a renal transplant patient, not in somebody who's about to have some sort of urologic procedure. uncomplicated cystitis can be made solely on history, signs, and symptoms without a dipstick, without a urine culture. And that is not a Singapore-specific recommendation. That is a global recommendation and guidance from the vast majority of developed countries and undeveloped countries, for that matter. So antibiotics remain the primary treatment because in the setting of acute cystitis, because they do reduce symptom severity and complications. But there are side effects with them, the antibiotics themselves or resistance development. And we need to keep in mind patient allergies when selecting the appropriate antibiotic, what their renal function is, because the different antibiotics obviously have different clearance mechanisms, and the patient, what they're willing to go along with. If they're not going to take a 4-time-a-day drug, we're going to have to find an option. So the choice of antibiotics in our guidance is driven by our local antimicrobial susceptibility data. We do not have live data. We don't have today's updated antibiogram. We have data that is reasonably recent from studies. We can look at hospital data, not as compelling as what has been collected in the outpatient setting, but we do have that as recent as 2021. But it's constantly updated, and it will impact subsequent guidance recommendations. The features of the antibiotic, we're selecting obviously antibiotics that'll reach the bladder and what patients are willing to tolerate, and again, what their ability to adhere to the recommendation. Some acute cystitis, not an insignificant percentage, will resolve without any intervention, anywhere from 15 to 30%. You don't, and I don't, and we don't know who that's going to be. So for the vast majority of patients that are symptomatic, we need to provide them some help. If you believe that this is a patient that doesn't require antibiotic, but may be able to tolerate mild to moderate symptoms, then nonsteroidals are a consideration. I've not had a lot of experience treating cystitis with nonsteroidals alone, because by the time they get to me in a tertiary care center, they have generally failed antibiotics and a variety of other things. But I can see where this might be a consideration for those who don't want to take antibiotics or have numerous antibiotic intolerances. They don't get symptom relief as quickly, and they often require subsequent antibiotic treatment. The antibiotics did provide better symptom relief at day 3 to 4 compared to nonsteroidals. So, but you can consider it if the symptoms during the first 3 to 4 days are mild or moderate, or the patient doesn't wish to take antibiotics. You can answer this question. I'll be quiet and let you read and respond. The answer is a C. That is the guidance recommendation. That's based on susceptibilities of the available urine isolates we have from an outpatient. It was I believe it was 300 or 400 isolates relatively recently, meaning in the last 2 or 3 years. And nitrofurantoin was the most reliable, 99% susceptibility. Amoxicillin clavulanate, Augmentin, was about 93%. So not bad. But when you get down to Cipro or cotrimoxazole, it drops down to about 80%. So empiric cotrimoxazole, empiric Cipro, there's a good chance we've missed the boat. So Augmentin and nitrofurantoin and fosfomycin. Fosfomycin susceptibility, it's not routinely tested, but when it has been, it's been greater than 95%. So it is certainly an option as well. So our first line, as mentioned, is nitrofurantoin, and the duration is 3 to 5 days. There's data that is not terribly strong, but reasonably compelling to suggest 5 days has a slightly better efficacy than 3 days. But we're talking about a 4-time-a-day drug. The efficacy is about 10 to 15% more than 3 days. So we have to decide whether a patient will tolerate a 4-time-a-day drug for another 2 days or not. So that's a risk that you need to, or a risk assessment you need to make with each individual patient. There are twice daily nitrofurantoin formulations. They're not available in Singapore, to my knowledge, at this point. At some point in the future, hopefully they will be. That'll make it a little easier on patients. But if they're unable to tolerate nitrofurantoin or for whatever reason cannot give it to them, then Augmentin is the option. And it is for cystitis, it's a 5 to 7 day drug for mild to moderate cases. What constitutes a severe case is purely subjective. There is no agreed upon definition of what is severe cystitis, what is a mild to moderate case of cystitis. It's basically what the patient tells you, I'm in severe pain or not. In severe cases, you might consider a slightly longer duration, but again, it's patient specific. Fosfomycin has appeal in that it's a single dose. But it does cause, on occasion, GI disturbance with a little nausea or diarrhea, and it is, I believe, a bit more expensive. In suspected uncomplicated pyelonephritis in patients presenting with sudden onset flank pain or tenderness, particularly when accompanied by other systemic signs such as fever, nausea, or vomiting, we are thinking of pyelonephritis. Again, sudden onset flank pain or tenderness, with fever, nausea, or vomiting, we're certainly high up on our list of our differential diagnosis. The diagnosis can't be solely based on symptoms and signs, so we do urine tests. Unlike uncomplicated cystitis, where we do not need urine tests, in pyelo, because this could represent stone, this could represent obstruction, this could represent infarction, there's lots of things that can cause these constellation of signs and symptoms. So we need to confirm with urine FEME or DIP or microscopy with urinary, urine culture. So the differential diagnosis is as listed there, and if we need to begin treating because it can lead to sepsis and bacteremia and renal abscess and that sort of thing. So it's important to diagnose and treat this promptly. Okay, I think everybody's on the right track. We need to do both a urine dip or microscopy and a urine culture. Part of this is the culture needs to guide us to, when we get it result back, to make sure that the empiric therapy that we began is effective. Now, one would think that the patient would return if they weren't getting better by the time the urine culture came back, but they may not, and it would be helpful to know what the organism is if they return to clinic and are still quite symptomatic. We don't generally, on first onset in a female in an uncomplicated pyelonephritis, need to do further investigations such as a CT or a KUB or anything else to look for stones or obstruction unless this becomes complicated or this is one of a series of issues of pyelonephritis. So we need to look to see if there's an anatomic or structural problem. And it's no longer uncomplicated, it is a complicated pyelonephritis. We would augment urine dipstick or a microscopy with a urine culture for the reasons mentioned. As mentioned, we would conduct urine tests, both dipstick or microscopy, plus a culture and sensitivity for everybody with suspected uncomplicated pyelonephritis to guide us for diagnosis and guidance. Again, different from uncomplicated cystitis, where we need nothing other than history and symptoms. Okay, and as mentioned, dipstick, we're looking specifically at nitrite and leukocyte and esterase. In the absence of nitrite or leukocyte esterase, they're those are very good negative predictive values. If you have neither one of those present, then it is less likely that this is a pyelonephritis. Unless we're imparting that this is a obstruction in the infected kidney is not draining urine into the bladder and thus not picked up on the urine dipstick, which is not a common scenario. A negative nitrite or esterase has a great predictive value for this not being pyelonephritis. So what antibiotic would you put her on empirically? She's not hemodynamically unstable. Heart rate is 66, drinking, eating, feeling fine. The answer is we would start empiric therapy, and our drug of choice is Augmentin. In someone with pyelonephritis, we should begin therapy and adjust therapy as needed. We shouldn't wait for the results generally. These people can progress and develop more complicated case with sepsis, et cetera. Again, our local isolates, ciprofloxacin and cotrimoxazole, relatively unreliable. Only you'll get about 80% of the cases. Augmentin, we're going to get about 93% of the cases. Nitrofurantoin, while it's great for cystitis, it does not achieve therapeutic levels in the kidney. So it is not an upper tract antibiotic. It is a lower tract antibiotic. That's what makes it unfortunate. It's the same for fosfomycin. Both of those are fine for bladder cystitis, but they're not reliable for treating upper tract and should not be used in that manner. I'll share the results with you. Prescribe amoxicillin and clavulanate for patients with uncomplicated pyelo and tailor the antibiotic choice when urine culture sensitivities return. Your next option is going to be cefuroxime. Again, it does achieve therapeutic levels in the kidney, not quite as reliable as Augmentin based on local susceptibilities. Again, first line is going to be Augmentin, and again, we're using a higher dose, and we're going for a longer period of time as compared to cystitis. And for cefuroxime, Axetil, those are the doses and duration. Unless it's a small person, my personal professional recommendation is go with a higher dose of 500 milligrams BD if you're using it. But because of the efficacy of cefuroxime, Axetil compared to amoxicillin and clavulanate, when you have a sensitive organism, the duration of treatment is 7 to 10 days as opposed to 10 to 14 days. So again, ciprofloxacin and cotrimoxazole, unfortunately, when treating urinary tract infections, whether upper tract or lower tract, not your odds are lower or less for being successful. Doesn't mean you won't get lucky, but they're not quite as reliable. And I think the answer is probably A and D. I would ask them to continue to complete their course of Augmentin. I wouldn't change antibiotics unless your culture suggests that it's resistant to your Augmentin. Again, changing it blind is not necessarily prudent. And refer the patient to the A&E, really no need. There's not much they're going to do. You've got the culture result. You can make a antibiotic choice. Consider adding nonsteroidal. I think that's not an unreasonable thing to give her some symptomatic relief. When to refer? Obviously, if someone has sepsis, if someone's in shock, or unstable, those are pretty straightforward. Let me get this thing closed so I can see as well. Other considerations, obviously, if their symptoms are getting worse despite your best treatment with the best available information you have, or they don't respond, or they're nauseated, or you're not confident that the oral antibiotics are going in and they need closer monitoring. You're concerned that they have complicated pyelonephritis, which means either abnormal urinary tract anatomy, or they've got an obstruction or a stone or malignancy or something else. Males, because it can often be obstructive uropathy due to a prostate that may be causing problems. If they're frail and observation or management is an outpatient, not prudent. When they're pregnant, they need to, pregnancy is a bit more of an issue. You have to worry about untreated or incompletely treated pyelonephritis potentially leading to complications with the pregnancy. Or if they've got diabetes or other comorbidities that concern you.
Yeah, thanks, Prof. David Allen. Maybe you can just answer some of the questions that are available on the Q&A. So I've collected a few questions. So the first question, does the degree of the white blood cell in microscopy worry you in the case of asymptomatic bacteriuria?
That's an excellent question. People have looked at that, have not found a correlation. So the answer is no. I will tell you that it is not a completely resolved question, but I think in general, there is no data that is compelling, yet that says a higher degree of pyuria, a higher number of white cells correlates with the likelihood of them developing invasive disease. I
Sure.
honestly, my impression, not my impression, my perspective on guidance is they're great for populations. So in general, these are great ideas. When I'm sitting across from a patient, so much of it is individualized. I need to understand the context of which I'm applying these guidance or varying from the guidance. That's is why we're not replaced by AI and algorithms now. We have AI and algorithms to give us a hint, but not to tell us specifically what to do for a patient. And every guidance says use your judgment. Yeah, sorry.
Yeah, agree. No worries. The next question is whether is it cost effective to set a culture at the first instance in an uncomplicated cystitis case, and will this affect subsequent management if the results, if you're treated antibiotic and subsequently you get a negative culture result?
Wait a minute. I know the use is and I will state that ACE is interested not just in cost effectiveness, but antibiotic stewardship. That is a big push here. So we can all have our own perspective, but just from the conversation, we're really antibiotic stewardship is trumps cost of efficacy. As popular, we see is quite a few resist. Yes, Cincinnati just sent off the culture. I understand what your practice is. We're trying to say for a population patient. I'm not sure I'd do that for every patient. I really wouldn't. I think there is compelling data just locally as well as internationally that says it's really not cost effective or useful. So I would say, again, be discreet and discretionary and not have that as your reflex practice.
Thank you. So the next question is whether we can use Augmentin 625 twice a day for uncomplicated pyelonephritis compared to
Yes,
the 875 twice a day because we don't have the 875 dose.
yes. The short answer is yes.
Would you have increased it to a TDS kind of dosing or would you have kept it?
Yes, I would consider, especially in somebody maybe who's over 50 kilos, I would probably go to TDS. Yeah. And
So it's
again,
a
it's a
dose of the
function of their
amoxicillin.
renal function, yeah, clearance, etc.
Yeah, okay. And what is the first line antibiotic for male UTI? I know that we have covered uncomplicated cystitis today, but maybe you would like to talk about it.
I wouldn't like to talk about it, but I will talk about it. I'm trying to focus. I think that's we're trying to be very discreet here in dealing with this. But again, I would by definition, a male UTI is complicated. Men are not supposed to have UTIs. So I would consider strongly using nitrofurantoin or Augmentin, but that is somebody I had to do some follow-up work on. They need further investigation. A woman, uncomplicated acute cystitis in a woman, we do not need to send off test of cure, urine cultures, urine FMEs, urine dips, whatever. We do not need to do that. Not because I'm being stingy, it's just because there's no value in it.
Okay.
I'm not paying
And
for it, so I don't
I
have to be
agree. And for males, I
stingy.
think we have to be prudent about, other diagnoses, prostatitis, STIs. So the other types also we need to consider.
Your cancer, blah, blah, blah.
Yeah. So the next question, in a urine microscopy, what is the epithelial cell count would render it as contaminated?
Oh, gosh. Um, there may be definitive criteria locally, Sky. I don't know if you want to answer that. In my mind, if it's greater than 5 or 10, I'm suspicious.
Agree. So we have to look at the test as stipulated by the laboratory. So each laboratory will have different counts to
Yeah,
be considered
thanks.
as contaminated.
Yeah, yeah.
Okay. And I think there are some costs here that's provided from the polyclinic
Okay.
point of view where the microscopy costs 580 and dipsticks cost $4 and urine culture is about $22. I think that
Thank
the
you.
pricing differs a little bit from the GP setting.
Okay.
Maybe we would like to take one question that was previously given to us. What are the role of urol sachets, urinary alkalinizers in UTI management, and does it reduce the efficacy if you use it together with nitrofurantoin?
So urine sachet is basically raises the pH of the urine through citrate, bicarbonate, etc. So that's the purpose of it, with the intention of decreasing dysuria. It does not in itself treat the urinary tract infections. It's just symptomatic relief. The problem is nitrofurantoin specifically works better at a lower urine pH. I mean, so we're potentially reducing the efficacy of nitrofurantoin. So yeah, so that's why the non-steroidals were mentioned as an option. Not they come with their own set of complications. I understand. I have used urine sachets to great effect, and I've used urine sachets to no effect. So again, I leave it to the good judgment of the managing physician to weigh the risks and benefits, but be aware it might impact nitrofurantoin efficacy.
Yeah. And the next question, is there a need to repeat the dipstick or the urine microscopy
No,
to ensure clearance? No, right?
no,
Okay,
no.
sure. And does a predominant more red blood cell more than white blood cell in the urine microscopy, does it tilt your diagnosis towards asymptomatic microscopic hematuria, or is it a bacterial kind of picture?
Rephrase that question.
So it's about the number of red blood cells versus white blood cells in the urine microscopy. Does it
Yeah,
change your management or does it change your
no,
diagnosis?
no, it does
So,
not. I mean,
so
you can have severe hemorrhagic cystitis due to urinary tract infections, which causes gross hematuria, to be honest with you. Not nearly as common as doing to CMV or adenovirus or some other viruses. But I, if someone came in with gross hematuria, I'm a little I'm going to think a little bit more. But if someone comes in with dipstick positive blood in the urine, and no, I'm not going to be troubled as
okay.
long as they have a positive leukocyte esterase and or a nitrite.
Yes, and at the end of the day, it also falls back on your clinical diagnosis
Yeah,
in the first place. Yeah.
yeah, yeah,
Okay.
yeah.
Okay, maybe we can just take one more question on the slide. Oh, we have one more question. How about patients who are penicillin or cephalosporin allergy? Can you what
Fortunately,
sort of
we've got the nitrofurantoin option with regard and fosfomycin option with regard to cystitis. In pyelonephritis, it can become a bit more complicated. So that might be somebody who I would consider um, referring.
Okay, can maybe we can take one of the questions that's on the slides. Question three, what happens if the patient presents with typical symptoms of urinary tract infection, but if you do a microscopy and the result is negative?
Yeah. So yeah, so that's when I'm thinking of other diagnoses. Sorry, I got distracted here by a text. That's when I'm thinking of other diagnoses. I mean, atrophic vaginitis or the painful bladder syndrome with interstitial cystitis or overactive bladder syndrome, kidney stone, sexually transmitted disease, maybe vulvovaginitis. I mean, there's lots of different reasons why someone can have what sound like urinary tract symptoms, but ends up it's not it. So I would certainly, in that scenario, potentially think about other causes of urethritis or vulvovaginitis, et cetera. Yeah.
Okay, can. So we have now come to the end of today's session. Thank you everyone for joining in. I know that we have a good crowd of private GPs as well as polyclinic doctors and even pharmacists who have joined us today. So if you can scan the QR code here or click on the link which I've pasted in the text box, this will give us some feedback as well as to clock your CME point as well. Once again, thank you, Prof. David Allen, for today's session, and it's been very informative for all of us.
Thank you for inviting me.